Good afternoon, and welcome to HealthSystemCIO.com All-Star Panel, the Art and Science of Population Health Management, a webinar tweet chat combo from HealthSystemCIO.com sponsored by Geneia. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. As I mentioned, we also have a tweet chat going on hosted by our Managing Editor and Director of Social Media, Kate Gamble. You can view it in our Media Viewer panel, and if you want to participate, you can open a separate browser and use the hashtag HSCIO chat. And we're going to be doing some things in your WebEx panels today. In addition to the tweet chat, we're going to have a poll question out there in your polling panel section, and that'll launch when I let you know, and you can answer that question then, and we'll review the results together. In your Q&A box, you can submit questions, leave the default set to all panelists, and we'll look at those later in the program, but you could send them in as they occur to you. And you could download the deck using the URL on your screen, and there's also a shortened URL at the bottom of each slide. Just so you see how we're going to spend our time today, we're going to go about 35 minutes with our main panel discussion. And on that panel, we have Frank DeSanzo, CIO and Chief Strategy Officer with St. Peter's University Hospital Health System, Neil Ganguly, VP and CIO at JFK Health System, and Dawn Milstead, VP Clinical Solutions with Geneia. So let's get right into our conversation. And first, we're going to get an overview of everyone's organization. So, Frank, would you mind starting us off?
No, my pleasure, and thank you for having me. So St. Peter's Health System is a large Roman Catholic healthcare system in central New Jersey, roughly about 475 licensed beds in a large hospital, about 122 of which are dedicated to our children's hospital. We do about 7,000 births per year and have one of the largest neonatal intensive care units between Philadelphia and New York City. So from a children's hospital perspective, we are arguably the second or third largest in the state of New Jersey. That's really what we're known for, women's and children's services, although we remain a full-service healthcare system. We also have a variety of other businesses, which I'm sure are familiar to all of you, ambulatory surgery centers, a variety of what we call big box or kind of retail medicine-based sites in Middlesex and Somerset counties, about 50 other clinic and practice locations, a large physician group, adult daycare center, and home care, skilled home care business. So St. Peter's has been around for over 100 years. Hopefully we'll stick around for at least enough more so I can retire.
I knew that was coming, Frank. I saw that coming. Thank you very much. Neil?
Sure. JFK is actually also located in central New Jersey. We're neighbors with Frank and his team. JFK Health System is anchored by a 400-bed acute care medical center. We have a 98-bed acute care rehab institute, and then 500 long-term care beds spread across 4 facilities in the region. We have a specialty in the neurosciences, so neurosurgery is one of our areas of focus, as well as family medicine and a number of other residency programs designed to kind of promote healthcare in the broader community. We also offer home care and hospice, and then we have a regional EMS service that serves 2 counties here in New Jersey. We've got a growing multi-specialty physician group that's tied into our ACO and other kind of ambulatory initiatives that we're launching, much like they are at St. Peter's, getting into the urgent care space and things like that. We all here in New Jersey, or in the northern part of New Jersey, participate in a regional health information exchange. So myself and Frank's organization both feed data into that regional HIE. And then we've got our ACOs that we formed as part of our drive towards population health.
Very good. Dawn, a little bit about Geneia?
All right. Thank you, Anthony. Geneia is a healthcare technology, analytics, and clinical services company formed and launched in 2012 with the purpose and intent to change the way and support the way healthcare is delivered to improve the lives of the consumers that we serve. You know, we are a mission-driven organization, and we focus on that intersection between population and personalized health. Our primary focus is on building solutions for our clients who are multiple constituents in the healthcare delivery team, help them better understand, evaluate, and manage the health of their populations. Using our analytics platform, our remote patient monitoring program, our Education and Research Institute, as well as our clinical services, we work with our clients to improve health outcomes, lower cost, and try to help restore the joy of medicine. And we currently serve more than 1 million consumers today. Thank you.
Well, that sounds like a nice mission, to restore the joy of medicine. All right, let's go with, start off with you, Neil, on this question. Give us an overview of your population health management projects and how they're going.
So our primary focus in population health right now is around our ACO. We actually have 3 different ACOs that are operating today at JFK. We've got a traditional Medicare Shared Savings Program-based ACO with 16,000 Medicare beneficiaries. Then we have a Medicare Advantage program ACO with Horizon Blue Cross, which is the local Blue Cross Blue Shield here in New Jersey. And we have over 8,000 beneficiaries in that. And are just launching now a commercial program with United Healthcare with over 7,500 beneficiaries. On top of that, JFK has added our self-insured employee, or a portion of our self-insured employee population into this ACO program, and we've got, of the 4,000 employees, we've got about 1,500 currently enrolled in this. Overall, just under 200 physicians and other physician extenders are participating in the ACO. We've got 83 practice locations spread across our service area.
Okay. Frank, you want to talk about some projects and how they're going?
Sure. I mean, you know, in addition to participating in a variety of ACOs, which are, I guess, relatively speaking, similar and similar in size to what Neil talked about at JFK, I mean, we're really trying to move into the kind of predictive analytics realm as far as not only the ACOs and preparing us to go at risk, but just to do certain things like reduce readmissions and really start to get prepared to go at risk, which I think New Jersey's a little bit behind the curve on. So we're looking at a variety of, you know, data analytics modeling tools that, and we're using these at least initially in our DISRIP program, which is focused on chronic diabetes, but we're trying to identify with a good sense of certainty, over 85%, who's most likely to return here over the next 30 days based on the characteristics that they present with, either in the emergency room or as part of an inpatient stay. And then we want to allocate a disproportionate amount of our social work and care coordination and quality department to working with those patients directly through call centers and the like, and other tools to ensure that they get the best experience here and they don't turn up here again unnecessarily.
Very good. Let's stick with you, Frank, and let's talk a little bit about the objectives of the program.
So the objectives for us are clearly to cut down on unnecessary ED visits and unnecessary hospital stays. And, you know, it's kind of difficult in one sense because we still get paid for those. So if you talk to the CFO or other people in operations, they still want those visits because for the most part, we're not at risk right now for those dollars. But, you know, understanding from a quality perspective, from a leapfrog perspective, and ultimately from a risk-based perspective, it's something we need to do. We really are trying to be out there at the forefront, again, of identifying these people and making sure that they don't come back. Some statistics I recently saw from the advisory board indicate that from one particular town in central New Jersey called East Brunswick, about 40% of the ED visits, and it's a relatively wealthy community in the sense that most people have access to care and things like that, and most people, I think about 82%, have a primary care provider. But yet the statistics the advisory board published about 2 weeks ago indicated that over 40% of the ED visits from that community are avoidable. So that's where we're trying to be. We're trying to be out in front of that and stop these visits and interact with these people in different ways, either through our outpatient services or medical home or, you know, skilled nursing at home or home health aides or what have you. So we're kind of trying to cut that off at the pass, so to speak.
Let me stick with you based on something you just said, Frank. Is this concept, and I've been, you know, this has come up repeatedly over the last few years, this concept of getting out of step from a financial point of view, moving into an at-risk world when really the reimbursement isn't set up that way, is that a real on-the-ground problem?
I think, you know, I think it depends a lot on several factors, quite frankly. I mean, first, we see it as part of our organization's mission, and we see, you know, prevention and health and wellness as part of our identity as a religious organization and part of our responsibility. But, you know, I think that, you know, it can pose a financial risk for organizations, particularly if they're not large, insofar as knowing that on the front end they may lose these visits, for which everybody right now still gets paid rather handsomely. I think it just comes down to strategically, you know, number one, if you want to take the long-term view, and then number two, quite frankly, can you afford it?
Right, right. Dawn, you wanna jump in on this and talk a little bit about this whole dynamic of moving to the new world when it's not quite here yet?
Yes, so I think, you know, as we look at, you know, fee-for-service to fee-for-value, that is a hard transition, and that transition from a financial perspective isn't a one-for-one at the time of change, right? So there's quality-based upside arrangements moving to the acquisition of risk-based, full risk-based arrangements, and those quality incentives don't keep time with the fee-for-service payments that I think that the, you know, health systems are used to. And that creates an inherent challenge, you know, but the government has, you know, said and continues to move forward with MACRA and the institution of new requirements that in order for the country to, you know, get on the right track, we've got to focus on, you know, the preventive type services to avoid the cost on the back end.
Neil, your thoughts on this discussion?
Well, I certainly agree with what I've heard from both of my co-panelists. We, like Frank, are also driving towards using predictive analytics and analytics overall to help hone in on managing our population more effectively. Our drive is to be able to get to offer the highest quality care at the lowest possible price. And obviously, to be able to do that, we need to make sure that that care is being delivered in the right setting. In fact, from a JFK standpoint, we're even trying to leverage our EMS resources, which could, with the downtime that those EMS rigs have between emergency calls, to be able to almost move towards a little bit of a home visit type model using paramedic resources, or that community paramedicine type concept. So I think we're all engaged in trying to shift the value curve and drive care delivery to the lowest cost place where we can still maintain quality. One of the challenges I think we face as a community organization, though, is, you know, what are the number of patients you have to support or have in your catchment area in order to effectively spread that risk out over time. And I think that's one of the challenges that may be driving some of the consolidation activity we're seeing in New Jersey, certainly, and probably around the country as well.
Very good. Neil, any more thoughts about your population health management objectives?
No, they're very similar to Frank's. Readmissions are a big area for us. We're looking at chronic illnesses, COPD, CHF, diabetes, transitions of care, an area of focus. We're looking at also getting out into the ambulatory area and doing some practice transformation activities to try and get these physicians through what we view as a very disruptive transformation phase. As Dawn was saying, this transformation is coming, and it's a tough one, particularly for the physicians. So we're trying to deploy as many resources as we can to help ease that transition.
You know, Anthony.
Dawn, yes, go ahead, please.
I'm sorry. Yeah, just one more thing there. You know, this is where Geneia is really focusing on, and that is, you know, consumers in geographic areas access services across multiple provider bases. And, you know, Geneia is really focused on, you know, bringing in disparate data sources to create a more comprehensive view of the patient, to assist health systems in understanding utilization within their system, which has been traditionally what they've been had access to, and to expand that view of those individuals who are accessing services elsewhere. And so, you know, we want to try to help create that more comprehensive view in order to drive those predictive analytics so that the resources deployed at the health system level are, you know, most efficiently used and focused on the right members in the population.
Very good, Dawn. Let me stick with you. It comes to, the thought comes to me that it's very important today for a health system to have solid leadership in the sense that you don't want to be out of step with what you're doing. So if you're spending money on technologies to help advance population health, get care done in the right settings, you also need to be moving into these at-risk arrangements. You can't be out of step with poor leadership that's not getting all the horses sort of moving in the same direction. Does that make sense?
Sure, absolutely. And I think, you know, that the interplay between technology and population health and the personal side of that is critical. And that personal side really gets deployed through the clinical care teams, care coordinators, social workers, and those individuals that both Neil and Frank have said are being deployed at their health systems to work with patients to help better manage their own care so that the utilization is appropriate. I think one thing, you know, in terms of how can tech leaders and, you know, clinicians work better together is, you know, to have a full appreciation for those critical components of population health management. The data is critically important. You know, technology needs to be robust. We need to be able to look at a multitude of sources to get the best view we can of consumers in geographic areas accessing care across health systems. Employ those algorithms and predictive analytics in order to identify who needs to be outreached in order to prevent the unnecessary utilization. And all that's very essential. The second component, coordination and collaboration, and this is where, you know, Geneia plays a role. We're able to take in that various data and then present the information up to all the constituents across the, you know, healthcare delivery team. You know, there's a robust amount of claims data with the payers, and the payers are deploying resources against these same populations. The clinical data and the EMRs from the healthcare providers and even employers are becoming more involved here. You know, how can we align all those resources so we're not redundant in the outreach for patient engagement? And that's the third piece, patient engagement, you know, probably the most critical piece. You know, they need to play a role in their, you know, in actively managing their own health. Lifestyle choices that they make impact their health status, and they need to have access to information that they have not otherwise had. So that patient engagement is really what breathes life into the data, the ability of the different players to coordinate. And I think, as you know, all of us are focused on a common set of measures, maybe for a different purpose, but this patient engagement nut is the one we're going to have to crack.
Very good, very good. Now we're going to talk a little bit more about leadership, and we may touch on the area that I described before about being in step. But we talked about your objectives. Frank, let's start with you on this. How are the objectives established from a leadership point of view? And the critical question is, are CIOs being involved in establishing objectives?
Okay, I think I'll answer the second question first.
Mm-hmm.
You know, I think with, everything that we've heard on this call from the other panelists, in addition to everything that's going on relative to healthcare reform, I mean, IT certainly, more than ever, can be found, I think, at the center of all this change. I mean, it's not the driver. Obviously, healthcare reform and other issues are, but it certainly is the facilitator. And, the fact that we're going to have to make real-time decisions, mining through an enormous amount of data, keep that data secure, and at the same time continue to upgrade the level of care that's provided vis-a-vis technology, both from an inpatient and outpatient perspective. I think all those things mean that hopefully organizations out there are, if they haven't already, realizing that, IT has a major seat at the table as various healthcare institutions and providers, cope with and try and succeed under, or on top of the shifting sands of healthcare reform, let me put it that way. So, our organization certainly sees IT as a strategic enabler and potentially, in some cases, even a differentiator from a competitive basis. But certainly, hopefully, other organizations are doing that as well. And I think when you start to see the proliferation of, IT-enabled apps out there around patient engagement and such that healthcare systems are launching, I think that also shows that, IT is being called upon to play a different role than it ever has before. As far as how the decisions are made, in the case of St. Peter's, the decisions get derived from the strategic plan. So we have a strategic plan, part of which is called St. Peter's 2020. And, we sit around and we try and figure out through a variety of means, what the hospital is going to look like in 2020. We don't take it out really more than 3 years at this point. And it's not only from it, it all really comes from what we think the patients will be like, how many, what the acuity will be, where are they coming from, how are they paying, and then let's try and work backwards from that to, right-size the organization and what capabilities will we need in 2020. So then we set goals and then try and work up to those goals that we set. So we work everything back from that, and then we'll do the same thing for 2023. So again, anticipating the kind of analytics that are going to be required to, as Neil said earlier, really give quality care in the right setting at the lowest possible cost. Those things then drive the kind of IT systems that we have to seek out and deploy.
Very good. All right, let's open our first poll, and we'll get that. Should be in front of you right now. Does the CIO at your health system play a role in setting strategy, population health management strategy, or is he or she only brought into the discussion after the fact to implement supporting technologies? Obviously, the question is, are they strategic or tactical? Are they being included in the conversation, or are they brought in after the important conversation is taking place? So we'll get back to that in a moment. Go ahead and take that poll, and we'll look at the results in a moment. Dawn, let me go with you on this question. How can CIOs and other technology leaders play a part in strategy and not just technology? You have recommendations there? Dawn?
I'm sorry.
That's okay.
A full appreciation. I may have addressed some of this earlier. All tech leaders, clinical leaders need to have a full appreciation of the need to align the tools and processes and incentives across all the players. And what a challenge that is with the multitude of ACO arrangements given the payer and the like. But to recognize that population health is part technology and part personal. And I'll say largely personal because, that's, my teams and I believe the clinical teams in your organizations really take the insights from the technology and analytics and use those insights to better engage individuals. And that's the personal part. That's the engagement part that is so important. And while to Frank's point, IT is playing a much different role, absolutely, it's how do we translate that role into action and get the potentially parts of the organization that aren't used to really being fully ingrained into the analytics and all the valuable insights that can be provided there. The most robust analytic solutions aggregate data from multiple sources. We're getting better views of the patient with these multiple data sources, and all the constituents in the healthcare delivery team, payers, providers, employers to some extent, and patients themselves, equipped with this integrated, more comprehensive information, really affords an opportunity to help us be more connected and engaged.
Very good. All right, let's look at the poll results. And this should be shared with you right now. 83% of our respondents say the CIO is setting strategy, and 17% say they're brought in after the fact. Neil, what are your thoughts on that?
I think it reflects where the industry needs to be. I think any organization that is seriously exploring population health or looking at just the viability of their operation in the currently evolving model needs to have the IT component represented at the strategic table. In our case, as CIO, obviously I'm not setting strategy. I'm a member of the team that's setting strategy. And one of my primary roles is an educational role. It's to make sure that my colleagues around the table understand the capabilities of technology and the limitations of it. And we can set some real clear direction as to how we're going to use that technology in the short term, and to Frank's point, longer term, and I agree with Frank, I mean, for us long term, 3 years is probably a lifetime. But where do we drive 3 years from now? How are we going to push things that will improve the usability of the tools we're bringing to the table? Because, and Dawn talked about the personalization component of it, if we can't deliver tools that our customers can really leverage and use effectively, we're going to struggle with getting value from the data collection tools and the data delivery tools. And yes, we'll have great analytic capability maybe behind the scenes, but we won't have that engagement that we need. And I think CIOs are, I think, shifting their focus and need to be shifting their focus towards not just the blocking and tackling of the pure technology, but getting into the usability of it, getting into the real adoption to make sure that we're making our tools as effective as possible.
Excellent. All right. Frank, let's go with you on the next question. How do you determine the technologies needed to meet the population health management objectives? So they give you, or you work together with them to come up with the objectives, then you got to figure out what technologies you need to get it done.
I think that's, oddly enough, I think you might think that's the easiest part, but I think that's become one of the hardest parts today, as the healthcare space has really been flooded, especially around, data mining, big data, quote unquote, if you will, and, predictive or data analytics. I mean, normally, let's say, traditionally, when you would go out and look for an EHR vendor, there are the key players in the healthcare space. You have your 3 or your 4 or your 5. You narrow it down to 1 or 2, and then you make an informed decision with the rest of your staff and your peers and supervisors. But in this space now, I mean, everybody plays, from the IBMs of the world on down. So there's a huge market out there for these kinds of tools. Other industries have used these successfully for years. So I think it's really incumbent upon the CIO to do his or her homework and really kind of take the blinders off when it comes to these things and see who plays best in my space. Is it a Cerner or is it an Oracle? Is it IBM or is it a McKesson Analytics package? You know, does Epic have the best analytical tools out there, or is it someone in the Gartner Magic Quadrant? So I think that's where it's gotten a lot tougher insofar as the amount of time that you have to take and the amount of vendors you have to vet as you bring in some of these tools that are relatively new to the healthcare industry.
Dawn, thoughts?
Yes, I'm going to go back to 3 points I made before. When it comes to, technologies and solutioning, in my opinion, it's around data, coordination, collaboration, and patient engagement. And your solution set needs to address those three major categories. First of all, from a data perspective, there has to be an ingestion of just tons of data from the disparate sources. And then you've got to enrich or curate that data, drive predictive models, risk algorithms, and then you've got to display it to those who can use it for the actual engagement to promote the behavior change. So that's the data piece, very, very important. And then the technology solutions must allow for a coordinated and collaborative care and information sharing. There's a lot of redundancy in the system because, a patient and being seen by one provider has a care plan in their EMR, the next provider has their EMR, and depending on who their payer is, there's a care plan in that EMR. So we've got to be better at allowing for that coordination and longitudinal care planning. And then, to the points previously made, patient engagement. How do we get the information into the hands of the patient so that they can become more active participants in their care and, provide the predictive insights to the clinical team so that they know who are most likely to engage and who are the most in need of engagement.
Very good. Very good. All right, Neil, let's go with you on this question. Population health management work spans many departments and areas of a health system. Can you talk about that, about how many facets of the health system it touches?
Well, it really touches all facets of the health system. In a way, we are trying to re-engineer how we're delivering care to a very specific population. I mean, we're taking our ACO projects or ACO initiatives as somewhat of an experiment in how to manage these kinds of populations. But ultimately, the goal has got to be to bring the lessons learned from the ACO forward into the broader general population. And that we've heard other panelists talk about how we want to reduce unnecessary utilization, how we want to improve the coordination of care. Well, these involve really changing how we communicate as caregivers, both within the four walls of institutions like our hospital, to outside those walls to our ambulatory providers, but then beyond the walls of our systems to other systems where Frank's clinicians can work with clinicians on my side to make sure that that patient doesn't not just show up at JFK for a readmission, but doesn't also show up at St. Peter's. And how do we really deliver tools that are going to kind of help us direct that is probably one of our greatest challenges. But in terms of how many departments are touched or how this kind of population health philosophy is going to affect the system, it's across the health system, both in the inpatient side and the ambulatory side. It's fundamentally relooking at how we are delivering care and managing our patients through their care delivery journey.
Excellent. Very good. All right, Frank, let's start off with you on this. How can technology leaders work with clinical leaders to further population health management objectives? We know how those clinicians can be.
Yes, we do.
I'm married to one. Go ahead.
I think, look, that's a tough question, and I think it varies by clinician, and I think you have to vary your own style as a CIO relative to the organization, the clinician, and what the goals are. But I think, usually starting with a clear set of goals that are focused around, improving the health and outcomes for the patients. I mean, that's usually a common ground that everybody can agree to. And then using clinical standards work backward from what the end goal is going to be, and then make a determination about how IT can help enable that goal. You know, whether it's through alerts in an EMR or through an outside interface system or something you develop in-house, whatever it happens to be. You know, I don't think it's rocket science. I think that, you know, obviously you can kind of bring rocket science into that if you follow Agile or things like that when you get to the position where you know what the endpoint will be. But I just think it's a collaborative, transparent discussion that has to take the endpoint of, you know, reducing readmissions around, you know, COPD or whatever it happens to be, and come to a mutual understanding with the clinical staff, who are usually in the best position to know, you know, what can be done, what do these people present with that could have been prevented, and then how do we go out there and educate them, prevent it, bring care to them in place, or whatever it takes to get us where we need to be.
Very good. Dawn, thoughts on IT and clinicians working together?
Yeah, I think that there's a ton of challenge here, and I'll go back to the discussions about strategy and the importance of IT at the strategy table. There's also, you know, clinical strategy for all the players in the healthcare delivery team. And I think the interplay between where, you know, providers are in their value-based transition to value-based reimbursement is an important factor that, you know, plays into IT and clinical strategy. You know, a question comes, how integrated are those? Clinicians really need specific and detailed information at the point of care to know who in the population needs help, when they need help, who's most likely to engage. And so I think tech leaders can really learn a lot about understanding the problems the clinicians are trying to solve so that they can drive insights through the technology solutions that the care team needs at the end of the day, because everyone's focused on, you know, the same improvement of outcomes, reduction or leveling of costs, and, you know, improve patient experience.
Very good. All right, now we're going to jump into some audience Q&A. So I want to remind everyone, if you have a question, go ahead, send it into the Q&A box and leave the default set to all panelists. So we've gotten a few questions in through our tweet chat. Neil, I'm going to go with you first on this one. How do you think MACRA is going to impact population health? Will there be significant changes?
You know, I think that the government overall has led this charge to drive us towards the pay for value instead of fee for service, and I think that MACRA is just another round in driving us in that direction. So yes, I think it's going to have a pretty significant impact. I think in some ways, though, it's helping us by starting to consolidate some of the measurements that, at least on the physician side, we're going to have to deal with to be able to report out on where we are in terms of our journey. One of our challenges historically has been that there are so many different regulatory levers kind of pushing us from the reporting side. Certainly as hospitals, we've struggled to be able to just deliver the data to the federal government. I think MACRA is going to help us a little bit in consolidating some of that. But overall, it's one more step in the direction towards truly accountable care.
Frank, any thoughts on MACRA?
Yeah, no, I agree. You know, although there's I think there's a couple of payment pathways for doctors with that. There's the, you know, there's the alternative payment model, and then there's the MIPS system. I mean, clearly it's ultimately going to push towards the value-based care and practice transformation. So, I mean, it's just going to be another step in the direction of getting the low-cost value-based care and ultimately being at risk for the care that we provide, whether you're a physician or whether you're a healthcare system.
Very good. All right, next question that is coming for our tweet chat. I'm going to go with Dawn on this. Can you please share some more insight on predictive analytics and readmissions?
Yeah, so one thing from a Geneia perspective that we do by bringing in data from multiple sources for populations, claims, clinical, patient-generated data and the like, is we are able to ingest that information and build models that, one, outline propensity for engagement, and then two, predict the likelihood of readmission, the likelihood of ER utilization. And by providing those insights, the clinical teams at providers, at health plans, at employers are able to focus interventions on subsets of the population to be able to try and modify behavior, work with patients to modify behavior to prevent that outcome that everyone's trying to eliminate or reduce.
Okay, very good. All right, next question that has come in from the audience. Please share your strategy in selecting the best analytic tool where you can best aggregate the information so you know that you're able to report for all of these different regulatory and quality outcomes and reimbursement reporting needs. Frank, I think you touched a little bit on selecting technology, but anything more you want to add there with that question?
You know, if I was really firmly confident in a selection for what the #1 tool was for doing this, I'd be happy to let everybody know. We're actually in the process of going through the Gartner Magic Quadrant, every vendor that's in there, including our current EHR vendor, which is McKesson, you know, looking at the technology and seeing what works best. From an ease of use and I guess basic number crunching perspective, most of these tools will get you where you have to be. I think the thing that we've found frustrating is there's very little integration on the EMR side. So some of the vendors we've talked to don't integrate with an EMR or EHR, but they're planning to do it, but only with Epic. Athena Health is developing their own, but it will only work within the Athena Health umbrella. McKesson and Allscripts have some nice products out there, but you know, it requires someone from care coordination or quality to go out and look at other screens and basically do things in tandem while they're working in the EMR. Nothing is really identifying people in the EMR based on analytics that I have seen that say this person is most likely to be readmitted. These are the things we need to do pre and post discharge to make sure that that doesn't happen. So that's where our frustration has been, and we continue to seek out partners.
Dawn, any thoughts?
Yeah, so I think, you know, the one thing that is very clear, and as a technology and analytics and clinical solutions vendor, is that care teams, regardless of where they are, cannot be expected to pull out of their workflows. And so in order for a partner to be effective, in my opinion, in Geneia's approach, is to not require folks to come out of the workflow, but we are capable of pulling in EHR into that common data fabric regardless of who the vendor is. And so it's not tied to a specific vendor. And then in partnering with the other players who have robust data, claims data, patient-reported data, whoever the partners are, to bring that in to serve it back up. This is a difficult issue to solve. I think that the first order, you know, what we lead with is our expectation would not be that anybody's going to step out of their workflow. Their workflow needs to be enabled by the aggregated, curated data to provide insight into that workflow. And that's the approach Geneia takes.
Dawn, I would disagree slightly. I would say that I think that the clinicians need to work with the technologists and the technology vendors to look at how they might need to modify their workflow to best take advantage of the technology. I think it's not realistic for us to assume that their existing workflows are going to just naturally support what needs to happen to collect that data appropriately. Combined with the fact that really there isn't a workflow. Every clinician kind of has a unique workflow that they've often developed over the years, and that lack of standardization, I think, is a part of the root of the challenge we're facing as technologists in this. And Frank mentioned how hard it is to get the data. You know, we talk about collecting that data from the EMRs. You know, it's technically feasible, but often they're high costs. And even if the costs were put aside, sometimes some of the vendors just don't want to support it. So I agree with what you're saying in principle. I just think that there's a line in between where we have to get the workflow of the clinicians to get to a more standardized place that is designed to work with the technology, not just assume that the technology will somehow work the way the clinicians want to work.
And I am going to agree with you fully. I think, though, that's going to be a journey, and the experience that we are having as we work to help our customers with greater insights is that we're attaching there. So that's that IT strategy, right, in alignment with the clinical strategy that's going to be so necessary to figure out how those, you know, workflow alignment occurs along with technology integration. I agree.
Frank, I'm going to bring you into this interesting discussion. And I think what we're really talking about here is, do clinicians need to show some flexibility as opposed to saying, you know, whenever you bring them a system or some technology, even if they've been involved in the selection process, which of course is a best practice, for them to say, nope, this is the way I work and this is the way it's got to work. And I think what Neil's saying is they've got to show some flexibility. What are your thoughts?
I think, you know, as a CIO and speaking for others, we've all been there relative to how hard it is to get physicians to change process and workflows, you know, but I agree with both my fellow panelists. I think that there definitely, per Neil, has to be flexibility on the side of the physicians. I mean, we're all being tasked in healthcare today with finding, you know, new and innovative ways of doing things. And the old ways just don't pass muster for a variety of different reasons. I mean, oftentimes those processes, even from a cost perspective, can no longer be maintained because of the reduction curve that's taking place on reimbursement. So I think there has to be flexibility there, right? I mean, at some point they went, you know, from whatever they used before, stethoscopes to a stethoscope, and now I hear you can do a lot better with an iPhone than you can with a stethoscope. So I mean, those kinds of changes have to come, and it takes a while, and it's tough. But I also agree, you know, that with Dawn that while it might be a modified workflow that the physicians are required to engage in relative to patient care, whatever that modified workflow is, these kinds of tools can't take them out of that and put them somewhere else that they have to look to get them where they need to be relative to value-based care and meeting the quality metrics that are going to continue to get ratcheted up. So I think it's a combination of both. Physicians have to be flexible, but I think, you know, once we have a new revised workflow for them, everything has to be right there where they can get their hands on it readily.
Well, that's an excellent place to stop and a great discussion. I want to thank everyone who's participated today. When you close out your window, you'll see our post-event survey. If you could take a few seconds and answer that, we'd appreciate it. I want to thank our panel, Frank DeSanzo, Neil Ganguly, and Dawn Milstead, and thank Geneia for sponsoring and making today's really great event possible. You'll receive an email when our archive recording has been posted to our YouTube channel within 2 business days, if not sooner. Those of you who hold the CHIME CHCIO certification, attending our webinars gets you 1 CEU, so let CHIME know you were here, and if you've asked us to let CHIME know, we will. Sponsorship opportunities, you can contact Nancy Wilcox, and if you need a certificate of attendance for another CEU program, you can use the final slide in today's deck. And you go to our website to see our upcoming schedule. So once again, I want to thank our panel, our attendees, our sponsor, and everybody have a wonderful day. Thank you.
Thank you.